So I'm Dr. Brian Durie, and I'm very, very pleased to welcome you once again to our 2018 ASH program. And it's wonderful to see, again, a very, very large audience for this session. And our team here, we're ready to discuss the new strategies for multiple myeloma care, and very importantly, what do we see as the next steps for the future. So just some housekeeping to begin. As I said, I'm Brian Durie, and you can see I'm based at Cedars-Sinai. I'm chairman of the Myeloma Foundation. These are my disclosures. Immediately to my right, I have Vincent Rajkumar, and he has no disclosures. Very good. Shaji Kumar to his right, from the same facility, he does have disclosures. So they're chatting about that. And then we're pleased once again to welcome Philippe Moreau, who is the head of the department in Nantes, France, and as we would expect, has disclosures from the companies that he's working with. And again, we're very pleased to have Jesús San-Miguel, now from Pamplona in Spain, and he lists his disclosures. And so the format this year is very similar to what we have done in previous years. There will be a case presentation, so all of the discussions will be based on individual cases. Following that, there will be a polling question, which you're used to from these in the past. You have your keypads. The keypads are very simple. You just need to press the number of the answer, the last number. You can change your answer. The last number that you press will be your response. After that happens, there will be a presentation by the faculty, and then there will be a discussion among the panel, and then obviously we would welcome immediate discussion. We're going to be discussing each case and topic as we go along, not at the end. So there'll be immediate discussion. And then we will finish up each segment by re-polling, not all of the questions, but we will re-poll some of what we think are perhaps the key questions. And so to start, we will ask you just a few questions just to describe yourselves. And so we will have these polling questions. And so which of the following best describes your professional designation? So if you could just answer that. And if the computer is fixed, we will actually get the percentages. And as I say, best describes. Okay, so most of you, 71% are physicians, but we have 13% pharmacists. How about that? Okay. So then if we can move to the next question, which of the following, again, best describes your practice? And there could be overlap, so just pick the one that best describes your current practice setting. Okay, 40% academic, 25% research, okay. 15%. So very interesting distribution this year. So the final question, or next to final question, where do you practice? And I'm sorry that we only have 8 slots, so we had to combine Canada, Central America, and South America. So I forgive you for that. But please answer as best you can. All right, look at that, 44% from Europe. We did know that, but that's striking in that graphic. Okay, I think then we have one more. Yes. How many patients? Yes, so this is helpful just to get an idea of the expertise. I think in the past we've been impressed with actually how many individuals see significant numbers of myeloma patients. So let's see what we have this year. Oh, we don't see this year. So if you could answer this question. There we go. Yeah, so 37% see 20% or more. So, and then another 15 and 10%. So substantial numbers here are seeing significant numbers of myeloma patients. So this is great, where we can be discussing patients that you do see in significant numbers. All right, so just to summarize what you'll be participating in for the next couple of hours or so, we will start with risk stratification, and then we will discuss where are we with the newly diagnosed patient, and then what is the current status of transplant and consolidation and maintenance. Moving on to the many options that we currently have in the setting of relapsed and refractory disease, and backed by popular demand, at the end we do have a summary of the current 2019 algorithms to summarize kind of where we are in the treatment process. So I'd like to welcome our first speakers for this session, Dr. Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota, who will present on risk stratification for plasma cell disorders. So please welcome Vincent.
Hi, everyone. Thank you for inviting me again, Brian. It's always a pleasure to be back here. Unlike what you might hear from the other speakers, which might not be possible right now in your country, what I'm going to talk about is probably going to be immediately applicable, like right now you can do it. So that's good. Where are my questions? Can we go ahead with the questions first? Okay. I have 3 questions to start off with. So we'll start with the first patient that I'm talking about, which is a 54-year-old man found to have elevated monoclonal protein. Monoclonal spike is 1.9 IgG kappa. Additional workup shows that the serum free kappa is 5.0, serum free lambda is 1.0, CBC, calcium, creatinine are normal. What would you recommend next? Bone marrow biopsy, bone imaging, bone marrow biopsy and bone imaging, bone marrow biopsy, bone imaging, and whole body MRI, bone marrow biopsy and whole body MRI, or uncertain? Go ahead and vote. Okay, so 45% of you chose bone marrow biopsy and bone imaging. And let's see what the next choice is. That's actually what the faculty also picked. So very good. And we'll go ahead with, while I present the discussion, why that's the right answer. So this patient undergoes the bone marrow biopsy, which shows 8% plasma cells, and the bone imaging, which is negative. So probably MGUS, patients watched annually for 3 years. And now in 2018, the patient presents with an increase in monoclonal protein to 2.5 grams, but still no symptoms. CBC, calcium, creatinine are normal, and we repeat the bone marrow biopsy because the M spike has gone up, and that shows 25% plasma cells. Oops, sorry, can you go back to the question? So please read the question very carefully. There's some trick question. Go back to the question again. Yep. Which of the following is not consistent with high-risk smoldering myeloma in this patient that we just heard? A free light chain ratio if it came back more than 25, 414 translocation. If the MRI showed 3 focal lesions, 8 to 10 millimeters in size. If the fish showed deletion 17p or uncertain. Which of this is not consistent with high-risk smoldering multiple myeloma? Please vote. Okay, So we have two groups that are dominating, 38% for free light chain and then 40% for the three focal lesions. So let's see how the faculty voted. Okay, so the correct answer is 3 or more focal lesions on the MRI. 3 focal lesions on MRI makes the patient has multiple myeloma, not smoldering multiple myeloma. So we'll talk about that as well. Oops. Can you go back to the question again? Yeah. So let's say this patient is myeloma and a few years pass, we've diagnosed the patient as myeloma. Which of the following in a myeloma patient will indicate standard risk disease? Del 17, trisomy 3, 5, 9, 15, 4, 14, 14, 16, gain 1q or unsure. Which of these abnormalities suggests standard risk disease? Please vote. Great, almost everyone got this right. Well, not quite. 1/3 got some other answer. 70% got it right, which I hope all the faculty got right. We'll see what happened with the faculty. Great. Okay, so I'm going to talk to you today about MGUS, smoldering multiple myeloma, and multiple myeloma. I'm not going to talk about anything to do with treatment. We're just going to try and talk mainly about the risk stratification and classification of these disorders. This slide actually illustrates basically what I think is the most current understanding of how myeloma pathogenesis is. We have normal plasma cells. Normal plasma cells, when they divide in response to an immune stimulation, such as an infection or some other antigen, one of 6 different abnormalities can happen by chance, and that includes trisomies or a translocation involving 14q, and that could be a 414, 1114, a 614, a 1416, or a 1420. Any one of these 6 things happens, you get an MGUS clone that is established. This MGUS is very similar to a colon polyp, like a normal colonic mucosa moving into a colon polyp. It's a benign is a limited proliferation of clonal cells. And then the second step is over a course of time, 1% of patients each year get something else. It could be a del 17, it could be a 1q gain, it could be any number of different things which we are still not sure of, RAS mutations, MYC translocations. And that causes the MGUS, which is like a polyp, to become multiple myeloma, analogous to colon cancer. And then once myeloma happens, over the course of a myeloma patient's lifetime, additional abnormalities happen, which can then make the myeloma more and more refractory as time goes by, and eventually the patient succumbs to the disease. The first things first, diagnostic criteria. In 2014, the International Myeloma Working Group changed the diagnostic criteria for MGUS, smoldering multiple myeloma, and multiple myeloma. And I want everybody to be on the exact same page in terms of what constitutes each of these 3 disorders. The first thing is to remember that smoldering multiple myeloma and MGUS are characterized or defined by absence of myeloma-defining events, whereas myeloma requires the presence of myeloma-defining events. That's the main way in which we split myeloma from MGUS and smoldering. And then we split patients who have a plasma cell disorder who don't have a myeloma-defining event into 2 groups, MGUS and smoldering myeloma. Why do we do that? Because MGUS has a risk of progression of only 1% per year, but smoldering myeloma has a risk of progression of 10% per year. So we split them into 2 groups based simply on the proportion of plasma cells in the bone marrow, less than 10% for MGUS, and the size of the monoclonal protein, less than 3 grams versus 3 grams or more. So if a patient has either more than 10% clonal plasma cells or more than 3 grams M protein and no myeloma-defining event, that becomes smoldering multiple myeloma. Myeloma itself is defined as the presence of myeloma-defining events in a patient who has a known clonal plasma cell disorder. Now, the clonal plasma cell disorder may be more than 10% bone marrow plasma cells or a biopsy-proven plasmacytoma. And then you have one or more myeloma-defining events, which includes your traditional CRAB features, hypercalcemia, renal failure, anemia, bone lesions, as well as 3 biomarkers that we added, which is if the bone marrow plasma cell percentage is 60 or more, that's automatically myeloma with or without CRAB, free light chain ratio more than 100, or more than 1 focal lesion on MRI. So this patient that we had in the case with 3 focal lesions, which were beyond the 5 millimeter cutoff size, is automatically myeloma, not high-risk smoldering myeloma, and that's why that answer was correct. Now let's start with MGUS. MGUS itself is classified into 3 different kinds of MGUS, and the reason we split it is because the type of problem that an MGUS patient will progress to is different based on the type of MGUS. So there are 3 types of MGUS. One is the non-IgM, that includes IgA, IgG MGUS, the IgM MGUS, and light chain MGUS. IgM MGUS most of the time progresses to Waldenstrom's macroglobulinemia. Non-IgM and light chain MGUS progress to myeloma. There is some differences in the risk of progression of these disorders. In general, IgM has the highest risk, non-IgM second, and light chain MGUS, the way we define it right now, probably has a lower risk of progression than non-IgM MGUS. This slide is very important, and I want you to keep this in mind. Many MGUS patients who see you, you might be the only physician that they see once a year, even though you're a hematologist. And what you need to remember is that the actual risk of dying from multiple myeloma or progressing to multiple myeloma, amyloid, Waldenstrom's macroglobulinemia, one of those plasma cell disorders is still quite low. It's only about 10% of all MGUS patients who will have this kind of problem. 90% of them will die of something else, non-related to the myeloma or amyloid or plasma cell disorder progression. So we need to make sure that we don't forget to monitor them for breast cancer, colon cancer, prostate cancer, heart disease, cholesterol, everything else that's important, and not focus only on the plasma cell progression part, because that risk is still low compared to the relative probability of dying from other things. This is from a classic paper that Bob Kyle published in the New England Journal of Medicine this year. Now, once you know the patient has MGUS, simply using the M spike size, the IgG type, and the free light chain ratio, you can divide this into 3 different groups. Patients who have all 3 abnormal, that means more than 1 gram, 1.5 grams M spike, and non-IgG type and abnormal light chain ratio will have a higher risk than patients who have everything normal. When you work up a patient with MGUS, if the patient looks like a low-risk MGUS, a small IgG MGUS with a normal light chain ratio, or a small IgM MGUS, or a very small light chain MGUS, and there are no complications, it's uncomplicated, then you don't need to do a baseline bone marrow biopsy and a bone survey. You can assume that they are MGUS, check them in 6 months, and only if there is a change, do those things. This is more than 40 to 50% of MGUSs that you can spare a bone marrow biopsy and bone imaging by following this rule. When you do a bone marrow and bone imaging on these patients, it's very unlikely you will upstage them to something else. All other patients should get a bone marrow biopsy and bone survey. How do we manage MGUS patients? We follow them in 6 months. If they are stable, if they are low risk, then you don't need to follow them at all. You can just follow them only if symptoms occur. This is the current IMWG recommendation. Whereas if they're intermediate or high risk, it's a bigger MGUS or it's non-IgG, then you would check them annually once a year for life. If there is an increase in the M spike or some other abnormality, then you will work up for multiple myeloma. Second, smoldering multiple myeloma. Smoldering multiple myeloma was a term coined by Bob Kyle and Phil Gripe in the 80s. Smoldering myeloma, as I mentioned to you, has a much higher risk of progression than MGUS. Even though we took 3 different groups of patients and called them as multiple myeloma, that is those without CRAB features who have one of those features, we are now classifying them as myeloma. That's still only a small sliver of patients. By and large, most of the smoldering patients are still in the smoldering category. And they can be divided into those who have a very low risk of progression and those who have more like a 25% per year risk of progression by using various criteria. And these criteria define patients as high-risk smoldering multiple myeloma. Why is it important to identify them? Because the early trials right now show that if you take high-risk smoldering multiple myeloma patients and you intervene early, as they did in the Spanish trial here with lenalidomide and dexamethasone, you can see there's a dramatic improvement in progression-free survival with the intervention. This needs to be confirmed, but this tells us how much research is important for the high-risk smoldering multiple myeloma patient. Here you can see even the overall survival can be improved by early intervention in the high-risk population. So how do we define high-risk smoldering multiple myeloma? Well, here are some of the factors. Any one of these will classify a patient with smoldering myeloma as high risk. Patients with very high M spikes, patients with high light chain ratios, that's not quite 100, but very high nevertheless. Abnormalities like deletion 17p, 414, or gain 1q. An evolving pattern, like the M spike continues to rise, or increase in circulating plasma cells. Here is a new risk stratification system that was proposed as the Mayo 2220 system, which is basically patients who have a bone marrow plasma cell percentage more than 20%, M protein more than 2 grams, and free light chain more than 20 for the ratio. You can see here, if all three are abnormal, you have a much higher risk of progression than if nothing is abnormal. How do we manage smoldering multiple myeloma? If you have a patient who's potentially smoldering myeloma or multiple myeloma, you are looking for myeloma-defining events. Clearly, if the patient has CRAB features or one of the other myeloma-defining events, we are going to label them as having myeloma and treat them. If they have no myeloma-defining events, they are considered as smoldering myeloma. And if the patient is low risk, that means absence of all the high-risk features that I listed, then those patients, everyone is comfortable with just observation. We just watch them every 3 to 4 months. The high-risk smoldering myeloma, right now there's a high interest in clinical trials for this population because these patients are at 50% risk of progression within 2 years. So in these patients, a number of clinical trials are available, and we encourage patients to be put on them. The gray area is patients who have multiple high-risk factors who are smoldering, who are so-called smoldering, but they have multiple high-risk factors. Or if the M spike is rising as you are following them, but they still don't meet the criteria for myeloma. That's a gray area. And I think based on the Spanish trial, some of us will consider treating a few of these patients as multiple myeloma. I told you there are a number of clinical trials going on in smoldering myeloma. One of them is a strategy of just getting drugs approved. That will be trials such as lenalidomide versus observation or DARA versus observation. Some of this is a strategic trial where we are trying to improve the outcome of smoldering myeloma by doing more intensive therapy to try and see if we can prolong overall survival of patients. And most exciting is that there are some trials such as the CAESAR trial, which is done in Spain, and the ASCENT trial, which is led by Dr. Shaji Kumar, which are really going all out to see if we treat patients with smoldering myeloma at an early stage before they have symptoms, is it potentially possible to cure myeloma? So there are all three types of trials going on. All of us are doing all of these three types. It doesn't mean we favor one type or the other. We just think we need research in the high-risk treatment, high-risk smoldering myeloma patients to improve outcome. Which of these three approaches will be successful, time will tell. Finally, I'll close with multiple myeloma, and I won't go into the treatment of this disease, but mainly the risk stratification. We have a paper this year that Dr. Kumar and I wrote calling it multiple myelomas. It's just like there are many, many types of lymphomas. We don't call it just lymphoma and have a lecture on that. But myeloma is much rarer, and therefore we pooled a number of different diseases, and we are calling them myeloma. But it's really 6 different diseases at the minimum. Where's the next slide? There you go. There are 6 different diseases that are basically called as myeloma. There are more than 6, but these 6 are the big ones. And this includes about 40-45% of patients who have trisomic type of myeloma. They have extra odd numbered chromosomes. And then some who have translocations involving 1114 or 614 or one of these other translocations. Each of these are considered a primary cytogenetic abnormality. And the complicating thing in myeloma is that any one of these 6 types can then get a secondary cytogenetic abnormality, which then affects the outcome even further. So for example, you can have a 414 myeloma, which then gets a deletion 17p on top of it. And that makes myeloma a little bit more complicated than many other diseases that we deal with. Here's a simple slide for cytogenetic risk stratification of myeloma. You can see that the disease aggressiveness goes as you go from trisomies to 11, 14, 614 to the 414, 14, 16, 14, 20, which have the highest risk. So the disease aggressiveness goes up. Any of these can then get deletion 17p or p53 mutations or gain 1q, and the disease aggressiveness goes up with the acquisition of these secondary abnormalities as well. Now we have, when you get more than one of these, so if you have a 414 and a deletion 17p, that's worse than having either one alone, and that will be like a double hit myeloma. And if you have 3 or more high risk abnormalities, the risk of the prognosis is even worse, and so that's triple hit myeloma. The revised international staging system takes the cytogenetics that I just talked about and adds to it some other prognostic factors that we know quite well. That's beta-2 microglobulin, LDH, and albumin. Puts the high-risk cytogenetics, everything together. I don't want you to memorize this, but simply know that the revised international staging system takes all of these things and puts them together and divides myeloma into 3 different groups. And each group is associated with a different prognosis. So the revised international staging system is what we are currently using in clinical trials for risk stratification. I'll close with plasma cell leukemia, which is an odd entity, but just so you know that when you have more than 5% plasma cells in the circulation on a regular CBC, that is associated with an outcome that is much worse than even high-risk myeloma. Now, ordinarily, we call only more than 20% plasma cells as plasma cell leukemia, but our studies now, there are 3 studies which show that even 5% circulating plasma cells on a regular CBC is really more aggressive than even the high-risk myelomas. So in summary, we have in myeloma a new diagnostic criteria which was introduced in 2014. We have a molecular classification based on primary cytogenetic abnormalities that divide myeloma into at least 6 types. We have a new risk stratification system for myeloma called the Revised International Staging System. Similarly, there is a risk stratification system, the 2-20-20 for smoldering, and the MGUS based on a light chain ratio and M spike that I talked about, and the RISS. Thanks so much for your attention, and that's all I have.
So thank you so much, Vincent, for that comprehensive overview of the early disease diagnostic and treatment implications. First of all, any comments or questions from the panel? Jesus?
Yeah, I have a comment. First of all, I mean, I really enjoy, very, very good talk. But regarding IgM, monoclonal gammopathy, in my current practice, I tend to do a bone marrow in these patients because with a small spike, they may have either lymphoma or Waldenström macroglobulinemia. And just to have the correct diagnosis is my current practice. What do you think about?
Again, you know, I use the word uncomplicated. So if the patient, what I struggle with is if a patient with has a 0.5 IgM and the hemoglobin is 15, do I really think that the patient could have a lymphoplasmacytic lymphoma? And if so, would I really treat?
Okay. So I actually have a similar question. In patients with MGUS who have numbers which are close to the 1.5 or the 8, do you have a different strategy to make sure if they have low-risk MGUS or maybe something more advanced where a bone marrow might be required? Because this is a discriminator to do that bone marrow test.
So the answer is like anytime you think that something is not right, do a bone marrow. Anytime you think something is not right, do a bone survey. If you're very comfortable that the CBC is 100% normal, the calcium creatinine are normal, and the M spike is small, if it's 1.4 and you're uncomfortable, do it. But if you're totally comfortable because it's smaller than that, or if it's only a fixed positive MGUS, there are 5% of patients in the world who have a monoclonal gammopathy if we define it the way we do. That's millions of people. I don't want to put millions of people into a bone marrow bone survey if the yield is extraordinarily low. They did a study in Italy where they said, suppose we did a bone marrow on all of these patients and a bone survey on all of these patients. How many smoldering myeloma would we find? They found 2%. So yeah, I'll be wrong 2% of the time, but I will know within 6 months if I was wrong, because I'm going to repeat the test, and if it's gone up, I would always do it. So you can resource-wise save a lot of resources, and discomfort-wise spare your patients a lot of agony by being a more risk-adaptive approach to these two tests, which I think are quite expensive and or invasive.
Yeah, so perhaps a little bit more careful follow-up initially, just to be more certain. So do we have any questions from the audience?
Could I ask about...
There's a microphone coming. There you go.
It's working.
My name's Tony Blau. I'm wondering about amyloidosis. So M spike, and even if I'm not worried about it progressing necessarily to, smoldering or active myeloma, it'd be great to pick up amyloidosis before symptoms kick in.
Right.
And what are you thinking? What's your thought?
So I think a good question. So what do you think about being cautious about possible amyloid, Vincent?
Absolutely excellent question. In general, when we are following MGUS patients, we are just checking only CBC, calcium, creatinine, and symptoms to try and see. People like Dr. Merlini, Dr. Gertz, Dr. Dispenzieri have raised the question, should we be checking at least an NT-proBNP so that we can capture some cardiac amyloid ahead of time? And it's a simple lab test, so if it's feasible, I'm okay with that. Most of the time with amyloid, you will have some symptoms, but if your question is, can we catch them ahead of time? So patients who have an abnormal light chain ratio, who are the ones who are likely to get amyloid, it would be reasonable at least for the NT-proBNP, because the cardiac amyloid is what you're trying to really pick out early.
I completely agree. And again, if there's any renal involvement, you would have picked it up on your 24-hour urine testing as well. So at least there are two organs you're going to be checking in that way.
All right. Okay, so we have time for maybe one or two more questions. Yeah, go ahead.
Yes, as part of the criteria, as part of the criteria, you mentioned normal free light chain ratio. For people with pre-existing renal dysfunction, it's not quite clear what normal values we should use. There have been a few papers published on the varying normals for renal failure. Can you comment on that? Or would you do a bone marrow in anybody who's got pre-existing renal failure for, known for other reasons?
Yes.
Correct. This is a great question on the light chain ratio in terms of what is normal. For MGUS, since simply we are saying is the light chain ratio normal or abnormal, that does pose a problem, because when we did the study years ago, it was 2005. Since then, we have learned that at least the binding site free light chain assay, which has a free light chain ratio of 0.26 to 1.65 as the normal range, may be too narrow, particularly on the kappa end, so that if patients have renal failure, you may have a ratio that's high, not because they have a clone, but just because they have an elevated level of kappa and lambda, and one ratio is going up. So I would say there's some wiggle room there. Up to 4, I'm okay with calling it as a normal light chain ratio. In smoldering myeloma and myeloma, that problem doesn't arise, because you're talking much more extreme levels, like with the 20 to 20 criteria, more than 20 for the free light chain ratio will be high risk. And for myeloma, more than 100 will be high risk. Those levels you won't reach with renal failure alone.
All right, thanks
Amira?
for that. So we have one over here. Yes, please, go ahead.
My question is regarding translocation 1416. In Palumbo trial, it was high risk, but it was only 80 patients in this. We collected 213 patients. It's a poster on this session, and it's not high risk, I think. The OS is almost 90 months, and I think it should be revised.
This is the point. Maybe Philippe, you want to comment on this? I think, did you have some similar findings?
Hervé Avelloiseau on behalf
Yes.
Hervé Avelloiseau on behalf of the French group as well looked at the outcome of patients with translocation 1416, and we did confirm that we didn't have, in fact, this adverse prognosis. But Vincent can comment on this because he has good ideas as well.
All right. Is it high risk?
1416 currently is considered high risk, and I will continue to consider it high risk until somebody shows me a study. The problem with any prognostic factor study is it depends on which setting you're doing it in. So for example, 1416 is one of those translocations that leads to extraordinarily high light chain levels and a higher risk of renal failure. So if you have a trial where systematically, which only includes patients with normal renal function, the prognostic effect of the 1416 is lost. So really to study prognosis, you need to take all patients who were seen in an institution or an organization over a defined period of time and say, how did they do compared to standard risk? So Dr. Kumar has done that with 1,000 patients. You take all patients and you look at trisomies 11, 14, 14, 16, 4, 14, del 17, 1q. And 1416 still seems to be adverse prognosis because you're taking all of the patients. If I said I will take only the patients who would have met the IFM trial criteria, then it'll go away because the mechanism by which 1416 is causing the high risk, you're taking away.
All right. Yeah.
I just wanted to add one thing, which is, again, when you look at the prognostic factors, it has to be very clear you use the patients or select the patients right from diagnosis, because if they have already survived a year or two and they have the chance of getting a test, it's no longer a valid prognostic factor.
Yeah, selection bias there.
Okay,
I think we just have one more question.
Two. Sidar and quick.
All right. Quick questions.
Quick question.
Yeah, this is regarding the correlation between MGUS and peripheral neuropathy. Many times the neurologist asks us to work up for M protein. We get something like 1.3 gram, and it is MGUS. Patient has got grade 3 sensory motor neuropathy, and what to do with MGUS in this situation.
MGUS and neuropathy.
So shall I just give a 1-minute summary on MGUS and neuropathy? So there are two types of MGUS neuropathies that we generally think about, IgM and non-IgM. IgM MGUS neuropathy is usually one that is called distal ascending demyelinating neuropathy. It's called DADS, DADS. And this neuropathy usually starts with the toes and then progresses upwards, and it's predominantly sensory. And if there is no other cause, it's possibly related to the MGUS itself. And we usually can treat it with either IVIG plasma exchange or rituximab, and the response rates are not very good. IgG, anything other than MGUS, IgM MGUS, if somebody says I have a neuropathy due to IgG MGUS or IgA MGUS, my initial response is it's probably not related at all. It's a red herring. They're unrelated. There are occasional non-IgM neuropathies, but those present like Guillain-Barré syndrome with both proximal and distal involvement. And those are treated basically like any other CIDP would be treated, whether you have an MGUS or not.
All right. Okay. Sorry. I think we should. All right. Fast.
Thank you. One last question. So I want to just get your opinion on the
20 minutes.
It's okay. It's coming.
just want to get your opinion on the divergent data that's been recently published on the free light chain prediction of whether or not that's going to actually progress to myeloma within 48 months, or 24 months, excuse me.
Oh.
Are you thinking about changing that as a myeloma criteria, I guess?
The 100, the ratio of 100?
Yeah.
So again, I can only go by the data that we generated. As Dr. Kumar pointed out, the study has to be agnostic to follow-up. So if you have a patient who's had a ratio of 150 for the last 5 years, and you then see whether they will progress in the next 48 months, that will not be 70, 80%. So what we did, I know what we did, which is take newly diagnosed patients, baseline, and when they had a ratio more than 100, with the added more than 100 for the involved light chain level, the risk of progression was 75 or 70+%, and that was reproduced by Dr. Dimopoulos. There's another study where that risk was 60%. The problem with high light chain ratio is that the first progression event is not likely to be anemia or back pain. It will be acute renal failure. Since the first progression event is so dangerous, I'm okay if it's 70% or 65%. So what? It's still very bad.
All right, so we'll stop with that for now. So before we move on, we will, let's go back and do some polling questions. And so the first question was, what additional testing would you do in this patient with early disease? What would be the next test that you would conduct? Okay, it didn't go to the, and the case continues with evidence of progression, and the questions are not coming up. I guess we are going to go and we're going to answer this third one, hopefully. So this third question was, which of the following are not consistent with high-risk smoldering myeloma? And so you did answer this one before. All right. Okay, why, gosh. Vincent. All right, very good.
I'm only looking at that blue. Who is the blue?
Yeah, we want, yes. Pay attention. All right, well, oh, we have something new here. What is that? Oh. I don't know. All right, well, thank you very much. That was a very interesting session. And so I will go forward with the next session, which is to discuss what are the options in the frontline setting. And this will be for patients who are eligible for transplant, patients who are not eligible, and then patients who have high-risk disease in the frontline setting. So the first case in this situation is a 55-year-old woman who presented with evidence of bone disease, had an IgA spike of 4.6, some mild anemia, normal calcium creatinine, 41% plasma cells. This patient did have these trisomies and had, in this case, a free light ratio of 157. So for this type of a patient, what treatment would you recommend for this woman with these kinds of features at baseline? All right. All right. I'm being told that not everyone is pressing their buttons anyway, so just press the... All right, so just make sure that you have those. Thank you. So, so very interesting, 64% have selected bortezomib Landex, VRD, and so obviously one of the issues in this frontline setting is that you might want to use VRD, but do you actually have access to VRD? And so what did the faculty say? The faculty said that they would use VRD, certainly if it's available, but you do have potential backup options. And so what I'd like to do first is to move forward and look at, well, what are the options that we have right now that would be recommended in the frontline setting. And this is an algorithm that will be discussed further at the end of our session. So in the non-transplant setting, Obviously, VRD could be considered even in that setting, and an alternative for elderly or frail patients is to consider the two-drug drop option of RD. For the transplant candidate, VRD really is the primary recommended therapy. Moving forward, as will be discussed in the next section, with the possibility of auto stem cell transplant with or without consolidation, and then to consider some of these further options as you move through the treatment paradigm. And so, what are the data related to the frontline options? VRD, or if it's available to you, VTD or VCD. Philippe will discuss his data indicating that if you have the choice, the initial early data with VTD is most likely preferable to VCD. At ASH this year, abstract number 1992, which is tomorrow in the evening, the SWOG trial will be updated, and this is the follow-up data with VRD in the frontline setting, which is one in which the VRD versus RD is offered to patients without the intent to have initial transplant, and is offered throughout the whole range of ages. And so there was no cutoff for age in this particular study, comparing VRD for the first 6 months versus RD, with RD maintenance for all of the patients in this study, not just RD. And so the updated information, which is in the abstract, indicates that with careful follow-up now out to between 7 and 8 years with this trial, the updated responses indicate, as you would expect, over a 90% overall response with the VRD versus RD. And what is particularly striking related to what is the continued evidence of benefit of VRD over RD is the higher occurrence of VGPR or better, 74.9 versus 53.2. And so in this follow-up, the responses and all of the outcomes have been reviewed both by SWOG and also an independent review committee that was brought in to review these updated data sets. Now, as was shown in the abstract, it's very encouraging that with these current data and reviewing current eligibility, a few patients for various reasons were deemed to be perhaps not eligible. There's some minor changes in these numbers. You can see here that the overall median PFS is 41 months versus 29 months. The overall survival out over 7 years now is very interesting. You can see that still over half of the patients, 55%, have an overall survival out beyond 7 years with frontline VRD versus 69 months as a median for the RD set. Some additional details will be in the poster that's available tomorrow. What I can show you right now is we've looked at this before. The overall survival landmarked at 12 months, it does show that that longer survival is linked to the depth of the response. In this curve here, you can see that the green curve is obviously those patients who had VGPR or better. So the patients with the deeper responses are obviously the ones having the longer survival. We have also relooked very carefully at the impact of age, and using multivariate Cox proportional hazard models, clearly the benefit of VRD is evident throughout the age range. What will be shown tomorrow in the poster are actually the median PFS values for patients under 65, 65 to 75, and over 75. And so you'll be able to see for the first time these median values, which I think are very important to see the added benefit of VRD over RD in each of these three age groups. So the question becomes, VGPR is obviously better. What should be the goal in this frontline setting as we look to new variations of VRD or additional strategies? And clearly we have strong data that achieving MRD negative is really the benefit in these patients who have a CR or have anything better than VGPR, that the achievement of MRD negative, particularly at the 10 to the minus 6 level, is that level which you can see here impacts an improved PFS and overall survival, as shown here in a collective analysis of the Spanish data sets. Just to give you an update, through the international working group, there is a separate group that has been established called the I-squared team, which is bringing together the main individuals interested in the role of MRD as an endpoint. And just to give you an update, that the trials that will be used to help in the submission to have a review by the FDA are listed there, a collection of trials that will be part of a package that has gone to the FDA for an FDA meeting that will occur on December 11th. So we are optimistic that this is a package that will be looked upon favorably and that we can have MRD as an endpoint within clinical trials, which is the goal of this particular submission. There will be a similar submission for the EMA. So the second question is, if the patient is 76 years old instead of 55 years old, how does that change in the age influence your selection of the treatment? And so let's vote again. So if the patient is 76 years old and has those features that you saw before, the trisomies, the bone disease, some mild anemia, what treatment would you select for a more elderly patient? All right, so VRD is selected here, but a significant percentage moving over to RD, and also some interest in some of the newer combinations using daratumumab. So I can see a range of choices for now and then perhaps moving into the future. So if we move forward, what did the panel here thought? They used mostly VRD, although Jesús, I think, is already looking towards the future, which is what I'll talk about a little bit as I present a few slides about what we're seeing now and what can we expect, which is one of the ideas for this meeting. Where do we see those options moving? So right now in the non-transplant setting, VRD would still be the normal recommendation, with perhaps VTD as a backup, if not, but with modifications related to age, to use VRD light. Obviously, based upon the risk, which we've talked about, one would use in the higher risk patients, deletion 14. You can see 14, 16 there, which we still are considering to be a higher risk, looking towards a Velcade-based maintenance. What was striking as far as data last year at ASH was the data from the Alcyon study where daratumumab was added to VMP, which is obviously one of the frontline choices in the non-transplant setting. And those data are very strong and showed the PFS benefit adding daratumumab to VMP. And this was quite revealing in that even in this setting that there was significant achievement of MRD, as you can see here, a much higher level of MRD on the right there with the addition of the daratumumab. But As is implied by Jesus San-Miguel's answer, I think that we are quite interested to see data presented. Now, unfortunately, this is a message for ASH, is that this late-breaking abstract is very exciting, will be presented on Tuesday. But nonetheless, Tuesday morning, but nonetheless, these data, I'm showing you what is in the abstract, which shows a very clear benefit of the daratumumab Revlimid dex over the Revlimid dex in the newly diagnosed patients not eligible for transplant. I would also draw your attention to the median survival in the RD arm, so that you can see here that choice of RD in the non-eligible for transplant population, a 31.9-month median. So this is also an important aspect to consider, especially if you might not have access to the daratumumab. So the third question is, what difference does it make if the patient has high-risk disease? And so what I've done here is I've selected 1Q plus, 17P minus, and 1416. So if those of you, as you've seen, would be certainly features of a high-risk cytogenetic profile, how would that influence your choice? So here are your choices where you can press the appropriate number. What would you do right now if the chromosome testing is abnormal? Okay, so a lot of people would just stick with VRD. And actually, as we'll see, this is a discussion that goes between Vincent and Philippe. What data do we have that carfilzomib Lendex would be better than VRD? You can see from the panel here that all of us except Philippe say that maybe we would substitute carfilzomib for Velcade for the high-risk patient. And so we can see how this discussion goes in a few minutes. So obviously, this is the treatment algorithm that will be discussed more later, but basically you can see here that for the good risk patients, the trisomies VRD, as you move over to your right, you'll see that the choice can become KRD versus VRD, but we're really looking for those data to strongly confirm that better choice, although we all have the evidence that we've seen in many settings where Kyprolis, carfilzomib, does appear to be, in many settings, a more potent proteasome inhibitor. So what will be these kinds of controversies that we have to deal with and think about moving forward? And so I just give you some examples of questions to be pondering as we move forward and for discussion. There will be new triplets to consider, KRD, also KCD or KTD, and then of course the DARA combinations, DARA-RD, but also DARA-VD, and then substituting ixazomib versus Kyprolis. But then what will be the status of the 4 drug combinations? DARA added in with VRD, VTD, or VCD, and so one can assume that those combinations, and we're waiting to see what will be the results of the Cassiopeia trial that Philippe will talk about, DARA, VTD. We're assuming that adding DARA to these potent frontline combinations will be very effective. It's also important to consider, and this comes out of the Spanish VRD autologous stem cell transplant, if you're trying to do better than VRD, what is the disease that is left? And so this is a very interesting data set from the Spanish team indicating if you look at the disease in the relapse setting, there is a preponderance of bone-related plasmacytomas and also chromosome findings that are of a double hit type, 1Q plus and 17P minus. So something to consider in terms of alternative backup therapy and to look at what would be subclonal patterns, which is something we're going to be seeing more of at the single cell level. And then to look more closely at all of our options now and to think which of those would be appropriate to add in the frontline setting? Should we be thinking to add an immune therapy, selinexor, venetoclax, even CAR T cells or BiTEs in the earlier setting, perhaps as consolidation? And so certainly daratumumab, this is what's going to happen first. There is an idea that for 1114, one could consider venetoclax perhaps, but the biggest question that we'll be focused on here at ASH is what will be the future role for CAR T therapies and for the BiTEs. And we are faced with data that we know already from BB211 from ASCO showing a median PFS of about a year. And so the question will be, should we be harvesting T cells on our patients in the frontline setting early and then consider what would be the appropriate best time to consider CAR T cells early in the disease? And so we also need to consider how we will evaluate response, and there will be changes in the timing of MRD assessment to capture the early impact of CAR T and the bispecific antibodies. And so as we move forward, I would just close with this comment that as we look at early disease and myeloma, the way that we consider who should receive treatment for myeloma is really morphing and changing. And this is where we are right now, where we are introducing in a trial fashion therapy for smoldering disease. But if we fast forward, what would really be ideal to think about would be to look at which patients should be treated like myeloma and which patients should not be treated at all. So this is to give you some perspective of where might be we headed for the future. And so I will close with that. Thank you for your attention. All right, so questions on this? Do you, I can ask, so do the others feel that with the new data, DARA-RD will become something that we would be strongly considering? I don't know.
We'll wait and look at the data, right?
If I would add, I think the best treatment should be used at the beginning of the disease. And in lymphoma, we use a monoclonal antibody together with the best drugs. Then I visualize that in the future, probably VRD or proteasome inhibitor plus an IMiD plus a monoclonal antibody will be probably the treatment of choice.
Yeah, use the best treatment early. I certainly support that notion.
Really? Not
right.
one question?
No, that's all right.
Guys, you got to step it up.
That's okay. We can go ahead.
Well, can I just make a comment then? So I just would be careful because for newly diagnosed myeloma, if you take 3 drugs and you get X% response rate or X number of months PFS, if you add a 4th drug, of course, that's going to go up. If you add a 5th drug, it'll go up even more, or 6th. And so we can't simply say that, I just increase the depth, therefore that's the best treatment, or I increase the PFS and therefore that's the best treatment. You have to have the metric ahead of time clear in our mind is in terms of what is feasible, what is actually feasible in countries where cost is also a concern. Many countries where we are saying let's do DARA-VRD cannot give VRD, let alone DARA-VRD. So we have to be realistic. To me, the metric is you have shown with VRD frontline a median overall survival that is not yet reached. That's beyond like 7 years. 7 years, 55% of patients are living. If you start VRD today, the first time the patient will need the next regimen, even without a transplant, is 4 years. A lot can happen in 4 years. So given myeloma is, like I've always said, more like a marathon rather than a sprint, I would like to save the best, I would like to save the most expensive drugs for later on until it's clearly shown that by using them early, you are going to improve overall survival. So overall survival should be our metric before we change. Or a head-to-head. If you did a VRD versus DARA-RD, and you said DARA-RD patients live longer, or like Dr. Kumar is doing a VRD versus KRD, and you show that KRD patients live longer, then you change. I think prematurely changing is not, I have a concern with that.
All right.
May I make a comment? You have said that the patients will not relapse until 4 years, half of the patients. The other half will relapse before. Don't forget that.
This is an important point.
Yeah, and the other, I mean, I'm really very sensitive as well as you about the cost and also about how many physicians in this audience have not even access to proteasome inhibitor and IMiDs. And you need to continue to treat the patients with an alkylator and a corticosteroids. At the same time, I think if we use the drugs late on, expensive drugs, probably the benefit is small. And I think the companies should be aware that they need to change the prices just to facilitate more physicians, more patients to receive such a treatment.
So absolutely, in the 777 trial, what we're looking at is the impact of the first 6 months, getting the 3-drug combo. That is really what is making the impact, and so using that strong early treatment is so important. All right, so what we're going to do is we will go back and ask one question again. How would you treat the older patient, the patient who is 76 years old, but has the trisomies 3, 5, 9, and 15. So how would you treat that patient? And the options we have are the same as before.
And this was in a patient setting that one patient told me, you're very optimistic because
All right, so we have a shift towards VRD or VRD light. So this is interesting. And then numbers, yeah, the DARA, yes. So I think that is a very reasonable choice. Then we're going to ask again the impact of the poor risk chromosomes. So the choices there, VRD, KRD, plus some other choices. Okay, so there is some movement toward KRD here. Okay, but still a spectrum of choices. So thank you for that. Okay, so we're going to move ahead. Thank you for that. And so we're going to move forward to our next section where we have 2 presenters. So both Shaji Kumar and Philippe will present their perspectives. Obviously, Philippe will focus on the non-US European perspective, and Shaji will focus more on the US perspective. So I'd like to invite Shaji to come up first and present.
So good afternoon, everyone, and thank you for being here this afternoon. So now that we checked out and made sure everybody's awake with all those questions, we can move on to the next part. So you already heard, how to diagnose these patients and how to treat these patients initially. But as Dr. Rajkumar just mentioned, treatment of myeloma is no longer just decide on one treatment and just keep going. It's more and more a multiple step process where you give each segment of the therapy, see how the patients do, and then decide on how we're going to continue to adapt therapy as we go along. So what I'm going to focus on is the US perspective on what you do after that initial therapy of multiple myeloma, and what are the data that we can use to justify the different steps that we take in these patients. So I will focus on the US perspective, and then Professor Moreau is going to come up here and tell me why every one of them is wrong. And I think with 44% European in the audience, I don't think I stand a chance. So let's go to the first question here. So it's a 53-year-old woman with no other health problems, comes in with increased back pain. And these are the results. Hemoglobin of 10.8, normal creatinine, calcium, LDH, beta-2 microglobulin of 2.8. The serum protein electrophoresis shows an IgG kappa of 3.2, and a 24-hour urine shows some monoclonal protein. The patient gets a whole body load of CT scan, gets multiple lytic lesions, bone marrow shows 40% involvement, FISH does not show any abnormalities. Was started on a combination of bortezomib and dex, and after 4 cycles of therapy, a repeat bone marrow biopsy shows no minimal residual disease, and serum and urine immunofixation are both negative. So it's a MRD negative disease by the current definition. So what would be your next step? So let's look at the questions, and please go ahead and vote. You have the whole spectrum of 8 choices. All right, now, yeah, and that is number 4. So proceed to a stem cell transplant followed by lenalidomide maintenance. All right, let's spice this up a little bit. Okay, first we take a look at the recommendations from the faculty. So it looks like we have a 60-40 split here. All right, so at least me and Dr. Rajkumar wants to do the stem cell transplant and len maintenance, and there's the other 3 would like to do some RVD consolidation in between the 2. Okay, now we're going to change this case around a little bit. So now we have the same, similar patient, but now have an LDH that's elevated, a beta-2 microglobulin that's 7.1 milligram per deciliter. And you do a bone marrow biopsy and FISH testing, and this patient has 17p deletion in more than 50% of the tumor cells. And this patient again is started on bortezomib, lenalidomide, dexamethasone, gets 4 cycles of therapy, and has a very similar outcome, no minimal residual disease left. Let's go ahead and vote and see what choices we would go with. So these are a little bit different than what you just saw. All right, now we are all over the place. Okay. Now we got our work cut out here. I'm not even sure which is which anymore. So, all right. So look at the recommendations by the faculty. Okay, so we are kind of following the same track here. We have a European preference for tandem autologous stem cell transplant. Dr. Durie wants to give some consolidation, and I think we are sticking with the Mayo approach here for the PI maintenance. All right. So when you think about the myeloma treatment paradigm, I think we increasingly talk about myeloma treatments being very complicated, and that's probably true when you deal with those patients who have had multiple relapses and plenty of choices in terms of what we can use for combinations. But when you think about the newly diagnosed patient, it is a far more simpler. We already heard about the diagnosis and the risk stratification. More or less, I think the community is unified in terms of how we stratify these patients and who is eligible for a stem cell transplant and not. And you already heard about what the initial therapy for these patients would be in terms of the triplets. And you also heard the debate about using the monoclonal antibodies. But once this patient's disease is under control, we know that if we just don't do anything, these patients are all going to relapse in the short term. So we really want to keep up the pressure on the tumor cells here. We want to give additional therapy to consolidate the benefits that we got from the injection therapy and continue the disease control for as long as we can. So there are 2 different goals. So the induction therapy is really focused on the disease control and reversal of the symptoms and signs. And in the long run, we really want to give them consolidation and maintenance therapy to maximize the disease control, and also with an eye on limiting the long-term toxicity that these drugs may be associated with. But the common goal is same. We want to get the tumor burden to the least level possible, and preferably in many of these patients, if we can get them to an MRD negative state, that is definitely a better outcome in the long run. So after induction, how do we provide consolidation therapy or maintenance therapy? Do we do a stem cell transplant? If we do a stem cell transplant, do we do 1 or 2? Do we need additional post-transplant consolidation, and do we need maintenance therapy? First of all, how long do we need to continue the injection therapy? Now, this is a retrospective study that in the CIBMTR that looked at patients who had a less than a partial response to the initial therapy. And in those patients, if they got an additional salvage therapy before going to a stem cell transplant versus directly going to a stem cell transplant, there was no difference in the progression-free survival or the overall survival after the stem cell transplant. suggesting that the change in therapy that patient needed was really the stem cell transplant. Now, obviously, this is retrospective data, but we also have prospective data from the UK trial where they actually looked at patients getting a cyclophosphamide, lenalidomide, dexamethasone, or cyclophosphamide, thalidomide, dexamethasone induction therapy. And if they got only a partial response or minor response, these patients were randomized to getting 2 more cycles of bortezomib, cyclophosphamide, dexamethasone versus directly going to a stem cell transplant. And the data clearly showed that there was an improved progression-free survival if you gave an additional line of therapy before going to a stem cell transplant, but there was practically no difference in the overall survival outcome for these patients. So I think there's fairly uniform consensus that we want to give patients 4 to 6 cycles of induction therapy in the transplant-eligible patient population before moving on to considering stem cell transplant. Then the next question that always keeps coming up and never goes away, whenever one new drug gets approved, we start asking the question, do we really need an autologous stem cell transplant anymore? So this is data from the Italian group suggesting, again, using high-dose melphalan versus using a consolidation with melphalan, prednisone, lenalidomide. You clearly see an improved progression-free survival and an improved overall survival for stem cell transplant. The criticism here has been maybe the melphalan, prednisone, lenalidomide is not really the best comparator for the stem cell transplant. So Professor Moreau and colleagues at IFM actually did a trial which looked at the contemporary regimen of bortezomib, lenalidomide, dexamethasone. So randomizing patients to getting a stem cell transplant or just lenalidomide, bortezomib, dexamethasone containing induction therapy. And the schema is as shown here. And what you can see is that when you do a stem cell transplant, you do get a higher response rate and also a deeper response in patients getting the stem cell transplant. So you have almost a 14% improvement in the minimal residual disease negativity amongst the patients who went to a stem cell transplant versus the ones who just collected the stem cells and continued on bortezomib, lendex. Now this translated to an improved progression-free survival, as you can see here for the stem cell transplant. And as of the most recent follow-up, there is no improvement in the overall survival. So what does this trial tell us? I think it gives us 2 important messages. I think the most important message is if you, in a transplant-eligible patient, the stem cell transplant after that initial induction therapy should be considered the standard of care, and you should encourage the patients to go to a stem cell transplant. But at the same time, if the patient does not want to go to a stem cell transplant, I think it's reasonable to tell them that collecting the stem cell and doing it later on is also an acceptable approach. What do you do after this patient has had a stem cell transplant? Do we follow that up with a second or a tandem autologous stem cell transplant? Or do we give additional consolidation therapy with the regimens like the bortezomib, lenalidomide, dexamethasone? Or do we directly go on to a maintenance therapy? Now, there are 2 trials that have directly looked at this question, and I'm going to talk about the one that was done in the US and the conclusions from that. And Dr. Moreau is going to talk about the EMNO2 trial and how he would interpret the data from that trial. So the STAMINA trial actually looked at patients who had a single autologous stem cell transplant, and obviously these patients were registered and randomized prior to the first transplant, and they were randomized to a len maintenance alone, or getting 4 more cycles of bortezomib, lenalidomide, dexamethasone consolidation, or a tandem autologous stem cell transplant. And all these patients had lenalidomide maintenance. Now, when you look at the primary endpoint of this trial, there is absolutely no difference in the progression-free survival between the 3 different approaches. And again, the overall survival is also comparable, again, with the caveat that the follow-up of this study is relatively short at this time point. So I think the recommendation for patients who are getting a bortezomib, lenalidomide, dexamethasone induction therapy, as is the most common practice in the US, and getting a single autologous stem cell transplant, there is no role for giving a bortezomib, lenalidomide, dexamethasone consolidation or a tandem autologous stem cell transplant. We can move directly to a lenalidomide maintenance. However, you also want to take into consideration there is some data from the European clinical trials, and the data from this multiple phase 3 trials is going to be updated by Professor Coward in this meeting. But the initial data clearly showed that patients with high-risk disease, the 414 translocation and the 17p deletion, those patients clearly seem to benefit from getting a tandem autologous stem cell transplant compared to a single auto transplant. Now, there is also the prospective data from the EMNO2 trial, which again demonstrated that there is benefit for the especially for the high-risk cytogenetics patients to getting a tandem autologous stem cell transplant. So what do we make out of these two trials, where again, we don't have the high-risk cytogenetic data from the STAMINA trial yet, but I think it's reasonable to have the discussion with the patient who have high-risk myeloma about considering a tandem autologous stem cell transplant. Now, what about the maintenance therapy? Now, we have this meta-analysis which incorporated the data from 3 different phase 3 trials, demonstrating that if you have a single autologous stem cell transplant and move on to a lenalidomide maintenance, you gain approximately 2.5 years in terms of survival, overall survival. And it seems to benefit the vast majority of the patients, with the exception of those patients who have high-risk disease. So this particular figure here shows the ISS stage 3 patients not deriving as much benefit, and there's additional data from this trial also showing that patients with high-risk cytogenetics also don't derive much benefit from a lenalidomide maintenance. What do we do for those patients? I think we can use the data from the HOVON trial, which looked at the combination of a bortezomib-based regimen versus a traditional VAD-based induction therapy, and again a bortezomib-based maintenance versus thalidomide maintenance, demonstrating that there's an improved overall survival for patients getting bortezomib-based therapy at induction and maintenance, and this benefit seemed to be much more obvious in patients with high-risk cytogenetics. So what's the recommendation? I think for all the patients who are getting a bortezomib-lendex injection, a single autologous stem cell transplant, the current standard of care would be to put them on lenalidomide maintenance if they have standard risk disease, and if they have high-risk disease, then consider using a bortezomib-based maintenance. Now, obviously, for the patients with the high-risk disease, we are always looking for newer strategies. Now, this is retrospective data from the Emory group, again showing that if you have a 17p deletion and you give these patients a bortezomib, lenalidomide, dexamethasone-based consolidation or maintenance, however you call that, you have actually a much better than anticipated overall survival, suggesting that a more intense approach to maintenance in these high-risk patients may be warranted. So what are the take-home points? I think in patients who are transplant eligible, an upfront stem cell transplant after 4 to 6 cycles of induction therapy with a proteasome inhibitor IMiD-based combination, irrespective of the depth of response, is the current standard. Certainly, a delayed autologous stem cell transplant is acceptable in situations where the patient cannot immediately proceed to an autologous stem cell transplant. If you are giving 4 to 6 cycles of a bortezomib, lenalidomide, dexamethasone induction therapy, an additional consolidation post-stem cell transplant with the same regimen is not warranted. Now, this might change as we have more drug classes available, and if we can give a triplet therapy which have newer agents which are non-overlapping with bortezomib, lendex, maybe we might at some point in future use a consolidation approach as well. Tandem transplant is not the standard approach, at least in the US. In high-risk myeloma, it's a discussion that you have to have with the patient. And finally, lenalidomide maintenance is a standard of care for patients with standard risk disease, and patients with high-risk myeloma, a bortezomib-based maintenance therapy should be considered. And I'll stop there and thank you for attention.
So, Shaji, thank you for this very good talk on the US perspective. So I will give now some data on the European perspective, keeping in mind that in Europe currently it is 11:30 p.m. So we have to be awakened for this talk, in fact. And these are the current European guidelines, very simple guidelines. For those patients that are eligible for stem cell transplantation, we are proposing in triplet induction, then stem cell transplantation prepared by MEL200, and maintenance with len until progression. And into these guidelines, we are not proposing a systematic consolidation. We are proposing a single stem cell transplantation, and we are never proposing a delayed stem cell transplantation. And we are proposing stem cell transplantation in patients less than 66 years of age or fit patients less than 70 in good clinical condition. And why are we proposing systematically upfront stem cell transplantation? This is based on the results of 2 important trials. The first one is the EMN02 study, the study from the European Consortium, with an induction with VCD upfront, and then patients were randomized to no stem cell transplantation upfront with VMP or stem cell transplantation. And the results are very clear, and they were presented twice at ASH by Michele Cavo. For progression-free survival, stem cell transplantation upfront is associated with a better progression-free survival as compared with VCD followed by VMP alone. And this is the French study published in the New England, RVD 8 cycles versus RVD plus stem cell transplantation frontline, and the maintenance fixed duration of 1 year in the two arms of the study. And you show this slide, the progression-free survival is in favor of the early frontline systematic stem cell transplantation, 50-month median PFS versus 36 months with RVD alone. And when looking at the prognostic factors for progression-free survival, the most important one is the achievement of MRD negativity. And the best way of reaching MRD negativity into this study is to use stem cell transplantation frontline versus RVD alone. You see the impact of stem cell transplantation to achieve MRD negativity 80% by 7-color flow cytometry. And when patients are reaching MRD negativity, the overall survival is improved with 7-color flow and also with NGS at the sensitivity threshold of 10 to the minus 6. OS is improved both before maintenance and after maintenance. So if you want to use stem cell transplantation upfront, you will reach a higher level of MRD negativity rate, and subsequently your outcome will be improved. So when looking at stem cell transplantation, we don't have to speak only about consolidation or maintenance, but induction is very, very important, and Brian discussed about induction. What is the role of induction? We need to have a fast control of the disease. We need, if possible, to achieve high response rate and MRD negativity with minimal toxicity. And it should allow as well an adequate stem cell harvest to be able to perform the frontline stem cell transplantation. And in Europe, the two standards of care were VTD and VCD, and more, and you heard about some polls here, we are using VRD as well. VRD is widely used in the US, is probably less toxic as compared with VTD, and it is, at least to my opinion, as effective. So it will be the future in Europe as well. And it could be easily proposed up to 6 cycles of VRD based on the Spanish experience. And the Spanish experience is very, very important when comparing VTD versus VRD. This paper was published in 2012 by Laura Rossignol. And in this study, our colleagues from Spain used, before stem cell transplantation, 6 cycles of VTD. And you can see that the VGPR rate or better is 60%. And you can have an adequate stem cell harvest of almost 4 million of CD34 positive stem cells. The same cooperative group published recently some data on VRD prior to stem cell transplantation. Same group, 6 cycles, and you see that the VGPR rate or better is 68%. It was 60% with VTD. And the stem cell harvest is also very good, more than 4 million of stem cells. But when comparing the toxicity of VTD versus VRD, and this will be presented by Laura Rossignol during this meeting, you see that the peripheral neuropathy rate is highly decreased with VRD. So you can use VRD up to 6 cycles very easily. And the same group looked at MRD data, and with 6 cycles of VRD upfront, you can reach a very high rate of MRD negativity at the threshold of 10 to the minus 6, 35% of the patients. That's a very high proportion of the patients. So how to improve on these results, and what will be the future? During this meeting, we are going to hear some data on KRD upfront, and I cannot show you any data, but please go and listen to Francesca Gay in 2 days from now with very good results with KRD upfront. But what we did with the French group and the Hoven group, we looked at the prospective comparison of VTD versus VTD plus daratumumab, and we looked at MRD negativity after 4 cycles of either VTD or VRD, and VTD or VTD dara. And the results will be presented at the next ASCO meeting. So these are 2 ways of improving on the induction part that is very important for the outcome of the patients. And this study will start very soon in Europe. What we are going to do, we are going to compare VRD upfront versus VRD plus DARA prior to stem cell transplantation, and VRD versus VRD DARA during the consolidation part of the study. So we are going to establish probably that the quadruplet combination is able to improve on the MRD negativity rate and the outcome of our patients. So we are not systematically proposing consolidation into our guidelines, but what is the role of consolidation? A short duration after stem cell transplantation in order to increase the quality of the response, the depth of the response, and with the reduced toxicity to allow maintenance. So what are the tools and what are the issues? We can use novel agent-based consolidation or a second stem cell transplantation. Is it necessary? What is the best option and what is the optimal duration of consolidation if needed? So these data were reported by Michele Cavo quite a long time ago, 5 years ago, and Michele will update these results, meta-analysis of phase 3 trials in Europe comparing a single versus a tandem stem cell transplantation. And at the bottom of the slide, this is what is written in the abstract. Tandem stem cell transplantation is improving overall survival with a very, very long follow-up. So I encourage you to listen to this oral presentation tomorrow. What we did also with the French group, we compared VTD auto without consolidation versus VTD auto and 2 cycles of VTD consolidation. And the PFS is improved when you are adding 2 cycles of VTD after stem cell transplantation. So we do have some data supporting consolidation or a tandem stem cell transplantation. And into the recent EMN02 study, in the stem cell transplantation arm, VCD and auto, some patients were treated with a single stem cell transplantation, and some patients were treated with a tandem stem cell transplantation. And Michele Cavo reported at the last ASH meeting the outcome of single versus tandem stem cell transplantation in terms of PFS, and 2 is better than 1. And for overall survival as well, 2 is better than 1, and you see the hazard ratio is 0.5, supporting the role of a tandem stem cell transplantation in young patients eligible for stem cell transplantation. And this is especially true for high-risk cytogenetics, but when also you are combining revised ISS2 and 3, for overall survival, tandem stem cell transplantation is better than single. And you can see the hazard ratio is quite good, 0.5 and 0.48. So we do have some data supporting for high-risk cytogenetics, especially tandem stem cell transplantation. This study also looked at VRD consolidation after the induction part in a randomized fashion, 2 additional cycles of VRD versus no consolidation. And again, the study was updated last year at ASH. You can see that with VRD consolidation, the progression-free survival is improved with a hazard ratio of 0.8. So we do have some data supporting the role of consolidation. And when you are looking at the results of the Spanish group, 6 VRD induction, stem cell transplantation, and 2 additional cycles of VRD consolidation, at each step of the strategy, you are increasing the MRD negativity rate at the threshold of 10 to the minus 6. That is a very important one. So Shaji, I think that we can use easily 2 cycles of consolidation VRD, and we are increasing the MRD negativity rate. That is a very, very important endpoint into our trials. And if I'm looking carefully at what you are proposing at Mayo, Vincent and yourself, for patients with high risk, consider tandem stem cell transplantation. So that's okay. Michele Cavo would agree with you. I'm not Michele, but Michele will tell this tomorrow for sure. So what about the US study, STAMINA study, a very, very interesting study design. After stem cell transplantation, patients are randomized to no consolidation, VRD times 4, or a second stem cell transplantation. The study design is optimal, very high number of patients, maintenance until progression in the free arm. So I'm perfectly okay with the study design. But when you're looking at the compliance for a patient point from the patient decision or physician decision, you see that only 68% of the patients who are allocated to the tandem stem cell transplantation arm did receive the tandem. So if you are taking out patients from a study, of course, the results will be totally biased, to my opinion. And similarly, 12% of the patients that were supposed to receive 4 cycles of VRD consolidation did not receive the 4 cycles for physician or patient's decision. So we should look at the per protocol analysis, and the results are the following regarding progression-free survival. The 2 best arms of the study are those with the tandem stem cell transplantation or auto followed by VRD. So a very good study design, but many patients were dropped out, and I think that the study is very difficult to analyze at the end of the day. But I agree with you, we still have question marks regarding the role of consolidation, and I think that outside clinical trials, we may recommend tandem stem cell transplantation in patients with high-risk disease. What currently we are doing in Europe is also looking at the impact of daratumumab as part of consolidation, and Cassiope will demonstrate probably that a quadruplet combination is very effective in increasing the rate of MRD negativity. So what about maintenance? And we know that we need sustained response following stem cell transplantation, and I'm showing you exactly the same picture of the impact of LEN maintenance into this meta-analysis on 1,200 patients. LEN maintenance is improving overall survival. That's a very, very important point. But we know that into this study, patients with high-risk cytogenetics and ISS-free does not seem to benefit from LEN maintenance. But we also have some data coming from the UK group, and Myeloma 11 study also looked at LEN maintenance versus no maintenance after stem cell transplantation. And our colleagues from UK that are outside Europe, UK is no longer in Europe, are also showing that LEN maintenance is improving not only standard risk patients, but also high-risk patients. So we do have some conflicting data regarding LEN maintenance, and nevertheless, we are proposing LEN maintenance for the majority of the patients. Can we use proteasome inhibitors? And Shaji, you showed some important data with bortezomib maintenance effective in high-risk patients. During this meeting, we are going to hear on the results of the Tourmaline 3 study, the comparison of ICSA maintenance versus placebo following stem cell transplantation, a very important study, and Thanos Dimopoulos will give this oral presentation. And this is the picture from the abstract book, in fact. You see that ICSA maintenance is improving the progression-free survival by 5 months as compared with placebo. So maybe LEN is interesting. This picture is showing that ICSA is also interesting. So why not combining these 2 oral agents? And this is what the Spanish group is currently doing, in fact, after stem cell transplantation and after consolidation. Patients are randomized to receive Lendex maintenance or Lendex plus ixazomib. So a very important academic trial looking at the impact of a combination on a PI and an IMID. And the Spanish group is also showing nicely that into this study, looking at the best response achieved when you're reaching MRD negativity at 10 to the minus 6, the outcome is very, very good. And some patients here are potentially cured of their disease with the combination of a good induction, a good consolidation, and a good maintenance. We are also looking at DARA maintenance into the Cassiope study, and a second randomization is comparing DARA during 2 years versus no maintenance. So in conclusion, the European perspective are the following: frontline stem cell transplantation and not delayed stem cell transplantation is standard of care. VTD and VRD are probably the best induction regimens prior to stem cell transplantation. The optimal consolidation has to be defined, and we are more and more using tandem in high-risk patients. And we need to consider the global strategy, and we have to try to improve each step of the procedure. And I thank you for your kind attention.
So thank you so much for both of those presentations. Certainly from the second presentation, you can see that there are some mild differences of opinion, perhaps. So do you have some comments, anyone on the panel first? Vincent? What about tandem? What about consolidation? What about the stamina trial?
Well, I mean, I think people just have to understand what's going on. There are 2 randomized trials with a very similar question, one done in the US, one done in Europe. One says there is no benefit of transplant, the second transplant, and there is no benefit of consolidation. So the US trial basically found that if you gave a transplant, then you can go straight to maintenance, because by giving the VRD consolidation, there was absolutely no benefit in PFS or overall survival. And by doing a second transplant, there was, again, no benefit in PFS or overall survival. The European trials found the exact opposite, that there was a benefit for tandem transplant and there was a benefit for consolidation. So when you have 2 trials, which are both led by great investigators, large studies, exactly opposite results, what is a person supposed to do?
So what about the 32% of patients who didn't get the double transplant?
So my interpretation for why the difference is, I think it really depends on where you are located. In the US, you literally have any salvage option you can think of, you can get it. So daratumumab, belotuzumab plus daratumumab. So when your patients have access to any salvage therapy that they want outside of a clinical trial, then the role of a second transplant and consolidation seems to be attenuated and basically disappears. So if you are in the United States and you have a well-insured patient who has access to everything, they probably don't get any more benefit from a second transplant or consolidation. That's the reality of the US trial. In Europe, you just told me how many patients could get daratumumab off study, and the answer was 0 in the Cassiopeia trial. So when access to salvage is limited by availability, then the transplant becomes even more important, because the transplant is another drug and it's very effective. So when there is no access or limited access, then I think you should consider a second transplant and you should consider consolidation. So I think really both trials can be applied only to the populations in which they were conducted.
All right, so questions from the audience on this? Or comments?
I have a question to all 3 speakers who discuss the role of consolidation. Do you think that the impact of consolidation depends on the treatment received before?
Definitely.
I mean, in the United States, in the Stamina trial, patients did receive a large number of VRD cycles prior to autologous transplantation, while in Europe they only received 3 to 4 cycles. And when looking at the Spanish results, the benefit of a second consolidation after 6 cycles of VRD is 4%. It's not that much. So I personally think that the benefit of consolidation depends on the quality and the duration of treatment prior to consolidation. And it will be even more true with quadruple combination. You will have many patients, let's say maybe 50% of patients achieving MRD negativity after transplant. Do they need consolidation? That we don't know.
Right. So I certainly agree with that. The number of cycles.
I fully agree. I
Yeah.
fully agree. I think
Yeah.
it's a very good comment and it's
Right.
really pertinent.
I think using a different regimen for the consolidation is probably what, if you're ever going to make an impact of consolidation, it has to be something totally different.
And also the response to the induction. Also, I think it's important how the patient was responding to induction. If you are going to repeat the same regime, and if the efficacy was moderate, then...
Right. I also agree with that also, yes.
Brian, we have a lot of difficulties to look at the data. Into stamina, and I agree with Jean-Luc, in fact, the quality of the response after induction matters a lot.
Yes.
And into stamina, patients could receive up to 1 year before stem cell transplantation. Some of them did receive Lendex, some of them did receive VCD, some of them did receive VRD, and I think that the quality of the response impacts a lot. So this is also a pitfall of stamina. But to be honest, and I did not mention this during my talk, when you're looking at EMN2 study, patients are either receiving VCD, single stem cell transplantation, no VRD consolidation,
right,
and maintenance, or VCD, single, VRD consolidation, and maintenance, or VCD, tandem, no VRD consolidation, maintenance, or VCD, tandem, VRD consolidation, and maintenance. So at the end of the day, we have too many groups, and the study is not powered to demonstrate that one group is better than the other. So stamina is not optimal, EMN02 is not optimal as well. So question mark regarding the role of consolidation, but I agree with Jean-Luc. Maybe when you are reaching MRD negativity after 6 cycles of VRD, single stem cell transplantation, you don't need consolidation. But this has
right,
to be demonstrated in a randomized fashion with a uniform treatment up front and a very good treatment up front.
Very, very good points. I fully agree. Yeah. So here?
So Tony Blau. So to what extent are these decisions individualized according to a patient? So I have myeloma. I looked at my M spike as it went down with RVD. And, great drop first cycle, a little less great second cycle, progressively. And then, I don't know, maybe between the 4th and the 5th cycle, you're not getting a lot. And then at All for Cure, we have 250 patient dashboards. We have patients that got a first stem cell transplant, got high-dose melphalan, nothing happens to their input. We have a few patients like that. So, am I going to be, if I'm that patient, am I going to be enthusiastic to get a second stem cell transplant if I haven't responded to the first dose of high-dose melphalan?
So, very, very good individual comment, yes.
Well, we always have to take patients' wishes into account and
Okay,
also patients' circumstances into account when making a decision. And
And
in a way, I think it's good that, in a way, I think there is good that we have divergent opinions because at least one of us is right.
well, okay. A question back here?
yeah,
So my question is regarding VRD consolidation, and the question that was presented to the audience for poll, patient achieved MRD negativity prior to transplant. And the consensus from the Mayo group appears to be that they would not offer RVD consolidation post-transplant and move on to maintenance. But what about patients who fail to achieve VGPR or better, or get a PR? Does that constitute an indication for VRD consolidation post-transplant? And how about patients who actually have higher risk cytogenetics to begin with? For instance, the patient has deletion 17p and will fail to achieve VGPR or better. Is that a patient that you would consider VRD consolidation post-transplant?
Yeah,
So I think those are very good questions. I think
good point, yeah.
In terms of, we still don't know how to adapt the therapy to the depth of response in a given patient because there are no prospective trials showing that if you take somebody who is less than MRD and give them additional treatment, to try to make them MRD negative, it's going to really impact the outcome. So I think at this point, I think we should think about this whole package as the best treatment option for a patient with myeloma. And irrespective of the depth of response at each disease stage, outside of a clinical trial, we should deliver the entire induction, transplant, and maintenance therapy. Now, clinical trials are looking at that specific question to see if somebody is not MRD negative, if you enhance the therapy, is it going to make a difference in your randomized clinical trials? Now, in patients with high-risk disease, I think we are willing to go out on a limb and say, these patients, whatever we have right now is not doing good enough for those patients. Shall we try something slightly different? And I think in those patients, and again, the data that was shown, that the people in the Spanish trial who actually were high risk, got MRD negative, did almost as good as the standard risk patients who are MRD negative. So I think we can extrapolate the data in the absence of prospective trial in those high-risk patients, and all of us would feel comfortable giving additional therapy to try and get them to a deeper response.
Right, so let's go ahead and see how all of this discussion has impacted your thought processes here, okay? So let's go back and see where we stand. What would you do for this patient? How do you view the role of autologous? Just to repeat the case so you can see. So this is a patient, a 53-year-old woman, a patient who had an elevated LDH, beta-2, had 17p minus in a significant percentage of cells, and so completed 4 cycles. So the number of cycles you can see becomes perhaps more important than you were thinking. And so what would you do next? So 4 cycles, what would you do next? Aha, number 6. Oh my, there we go. So tandem with RVD. Oh, so we have tandem. Wow. So, all right. So I think that now we have the audience in a very aggressive mood now to have a MRD for sure, one way or the other. All right, so we have moved you towards really having a maximum response in the frontline setting, which I think is actually a good idea to really have a rapid, strong response. But now we have Jesús San-Miguel to go through where do we stand in the relapse setting. So please welcome Professor Jesús San-Miguel.
Thank you very much, Brian. Are you tired? Please stay until the end of my presentation. And the reason is quite simple. I was last Saturday working at home preparing this presentation, and suddenly my grandson popped into the room and started to look what I was doing, and look into the program. He said, "You are the last speaker." Is this because your presentation is less interesting? And they put, as in the school, you are the last one. And I explained to him, no, Gonzalo, his name is Gonzalo, usually in concerts, they keep the best performance to the end. And you know, he left the room very proud. He said, my granddad is really impressive. Then please stay here until the end. Otherwise, he will get disappointed because there are some people here that will tell him. Okay, I'm going to discuss therapeutic strategies at the time of relapse. And I will drive this presentation through this clinical case. It's a 65-year-old woman that was diagnosed IgG, stage 2, with 1Q plus 414, moderate anemia, bone disease, and she was treated with VTD, autologous transplant, and lenalidomide for 2 years. She achieved a stringent complete response, but she relapsed 4 years later. Okay? Then, now the question. What would you do in this particular patient? Rescue, treatment followed by second transplant, bortezomib cyclo, carfilzomib lenalidomide, ixal lenalidomide, daratumumab len, daratumumab bortezomib dex, uncertain. Please vote. Okay. Okay, it's a split between dara-len-dex and rescue treatment followed by second transplant or carfilzomib len-dex. Let's see what the expert panel decided to propose. None of them support me. Then my grandson, again, will be disappointed because I was the only one that I proposed for this patient, and a rescue therapy. The rest proposed daratumumab, lenalidomide, dexamethasone. And the reason why at our institution we propose a second transplant rescue therapy with a second transplant is if the patient has a late relapse, more than 3 years without maintenance, at least 4 years if the patient has received maintenance after the first autologous transplant, and if the patient has an aggressive relapse, we reinduce with VRD, KRD, plus minus data if possible, and a second transplant. If a biochemical relapse, we repeat the initial approach, or the same as above, but plus a second transplant. Also, because we think this is cost-effective for many of the countries. As Vincent has mentioned before, this, in terms of cost, could be considered. Anyway, this patient refused to receive the second transplant. He was very fit, in fact, but only mild hypertension, but he was treated with Cyborg 8 cycles. He achieved a complete response, and he relapsed 1 year after stopping the Cyborg treatment. Okay, now is the question, okay? He has received this treatment. What will be the treatment of choice for you at this particular timing point for this patient? Carfilzomib lenalidomide, ixazomib lenalidomide, dara lenalidomide, dara bortezomib dex, lenalidomide dexamethasone, or uncertain. Okay, the majority will choose dara-len-dex, and in fact, this is what has been chosen by the faculty. I think here, everyone has agreed. It's not moving, yes. Everyone on the faculty has agreed on dara-lenalidomide dexamethasone. Let me review with you what is the data at this timing point for this particular patient. This can be a bit complicated slide, but I think is really comprehensive. I mean, this patient, if we consider that len-dex was the standard of care until recently, len-dex is associated with a PFS of approximately 17 months, but has been clearly surpassed in 4 randomized trials by triplet combination, comparing len-dex versus IXA, ILO, carfilzomib, or daratumumab. The increase in the PFS is shown here, 27 months, 8.7, 4.5, 5.9 months, and this is the hazard ratio. Therefore, according to this data, probably the best will be dara-RD for this patient. Nevertheless, in this particular patient, there was high-risk cytogenetics, and if you go down in this slide, you have here the median PFS for high-risk patients treated with dara-RD. And as you can see, it's not 45 months. This is the data that is going to be updated in this ASH meeting. It's 20.6 months. For the KRDs, 23, 19, 21. In other words, from my point of view, none of the triplets are able to completely overcome the high risk, but I think the combination of a proteasome inhibitor and imimid probably is worth just to be used in patients with high-risk cytogenetics. We continue with the patient. The patient was treated with len-dex. She didn't receive the triplet. They received len-dex until progression. On cycle 5, she was already in VGPR and maintained her response for 15 additional months, but eventually the patient relapsed under treatment with lenalidomide dexamethasone full dose. And here is the question. Carfilzomib pomalidomide, ixazomib lenalidomide dex, dara bortezomib dex, dara pomalidomide dex, ilo pom dex, or uncertain. Please vote. Okay. Dara pom dex, a lot of Americans should be here, followed by dara bortezomib dex or carfilzomib pomalidomide dex. People is very rich. Okay, let's see what the faculty has proposed. There's some divergent. Dara bortezomib dex 3, 4, and ilo-pom dex. Okay, let's now see the results based on triplet combinations using as a backbone bortezomib dex. There are 3 trials that has compared triplets based on bortezomib dex with panovinostat, with pomalidomide, and with daratumumab, and there is a doublet, carfilzomib dex compared to VD. And we have, again, the same information. Here you have the PFS for VD in this trial. It's approximately 8-9 months, very consistent in all the studies. And this is the PFS for the KD, 18.7, dara VD, and this is the increase in months with the triplet as compared, or the doublet in this case, as compared with the control arm, the VD. But when you analyze this data, I recommend you to be really aware of what is the population that was included in the trial. Because if you look, this patient was Len refractory, isn't it? Okay, and in the endeavor, in the dara VD, or in the panorama, the proportion of Len refractory patients were limited. By contrast, in the pomalidomide bortezomib dex, the proportion of Len refractory was much higher. And if you look to the high-risk population, the median PFS is 8, 11. In all of them is lower than in the standard risk, but particularly, I think the best result probably could go for the pomalidomide, bortezomib, and dexamethasone in the context of this type of specific patient, Len refractory with high-risk cytogenetics. The patient received, in this particular case, dara VD, achieved a partial response, only a partial response on cycle 2, and progressed with extramedullary disease on cycle 8. At this time point, again, I want you to vote about potential options. Okay, he has been exposed to almost everything until now. Lenalidomide, daratumumab. Then what is from all these possibilities, including carfilzomib pom-dex, ilo-pom-dex, trial with venetoclax, BCMA CAR-T, or selinexor, what is your choice? Please vote. Okay. Okay. CAR-Ts is, I mean, very attractive. Carfilzomib pomalidomide is right second. Okay, let's see what is the position of the faculty. No consensus. And this is important because at this timing point, it's very difficult to make decision in the patient. But let me share with you, at least in Europe, there are 2 drugs that has been approved for late stage of disease, late relapses. One is daratumumab, and the other is pomalidomide dexamethasone. A single agent, the efficacy is limited. Only 1/3 of the patient respond, and the median PFS is almost identical with pom-dex or with dara, single agent. This is the reason why we're not using any more single agent, and we have moved into combination. For daratumumab, carfilzomib dexamethasone was presented at the last year, and here, as you can see, the response moved from 31% to 85%, and the PFS goes around 14 months, much better. And also, you have the possibility of combining daratumumab and pomalidomide, as it has been proposed, and is very popular regime in United States. But also, since this patient has progressed under daratumumab, you can escape the monoclonal and you can go for a combination that is popular in France and in Spain. It is based on pomalidomide and cyclophosphamide, double the response rate, double the PFS at the cost of just cyclophosphamide. Or recently, it has been presented the data on Elo-Pomdex that I will share with you, or carfilzomib Pomdex that is going to be presented at this ASH meeting with 87% response rate and PFS. This is the Elo-Pomdex. This is a randomized study that was recently published in New England Journal of Medicine in double refractory patients, in which you can see there is a significant benefit for the Elo arm as compared to the Pomdex alone. But we need other drugs as well, because this patient has progressed under DARA. And I'm going to share with you 3 new drugs before discussing on the immunotherapeutic approach that you have proposed, the CAR T cells. The 3 new drugs that I'm going to discuss, one is selinexor. For those that are not familiar, is a selective inhibitor of nuclear export, then inhibit exportin. And what does exportin? Exportin, what add is take out from the nucleus of the cell the tumor suppressor genes and growth regulatory proteins, then activate tumor suppressors inside of the cell, which is important. As a single agent or in combination with Dex, is going to be presented again here at ASH, around 20%, 26% response rate. In combination with bortezomib Dex, the response rate significantly increased and goes up to 43% in bortezomib refractory, and is going to be presented also at ASH in combination with daratumumab. The second drug, very interesting drug, is venetoclax. It's a BCL2 inhibitor and is a critical, probably is going to be a critical molecule, particularly for patients with 11-4-14 and high ratios of BCL2 to MSL1, but not only for this patient. As a single agent, 21% responses, 40% in patients with 11-14 translocation. The efficacy, Philippe Moreau has shown, significantly increased in combination with bortezomib, goes up to 67%, 90% in bortezomib-sensitive patients, and also is being combined with another proteasome inhibitor, carfilzomib. And the third drug is melfuflen. Melfuflen is like melphalan, and the name is similar. It's a lipophilic alkylator that is activated inside of the cell. And again, at this ASH meeting, Paul Richardson is going to show the efficacy of melfuflen as single agent, 32% responses, 5.7 months. Look, if you have a test and someone asks you, the new drugs, single agent, what is the efficacy? You can say 30% responses. Median PFS, 4 to 5 months, maximum 5. Perfect, you will succeed. Okay, but probably for most of you and for many of us, the new avenue comes from immunotherapy. And we have now 4 major targets to treat the patients. One is monoclonal antibodies. The second are the checkpoint inhibitors and the new IMiDs. Third, adoptive therapy and vaccination. I will only discuss the new monoclonal antibodies. And there are 2 types of new monoclonal antibodies of high interest. One is the conjugated monoclonal antibodies. And we have already data on the anti-BCMA monoclonal antibody conjugated with monomethyl auristatin that has shown 60% responses, 43% responses in patients previously treated with data and refractory to data, with a median PFS of almost 8 months. The problem is the toxicity. 63% of the patients develop corneal problems. The other type of monoclonal antibodies are the bispecific, the monoclonal that target an antigen on the tumor cell, in this case BCMA, and also target the T lymphocyte, the CD3. And data that is going to be presented at this meeting again, very important information, 28% overall response, but this was an escalating dose. At the maximum tolerated dose, the response, the number of patients is still small, but the response was 83% at the maximum tolerated dose. It should be noted that CRS, similar to the CAR T cells, has been also detected with the bispecific monoclonal antibody. And here is what everybody is waiting for, the adaptive therapy, the genetically modified T cell therapy. And we have two types of approach. The CAR T cells that are more popular here, but also the TCR engineered T cells that has some advantage. They are HL restricted, but they have the potential recognition of intracellular antigens. The disadvantage is that the activation is TCR mediated. In the CAR T cells, you have the advantage that you have the possibility to insert other genes, and the possibilities are enormous. CAR T cells, many of them are different. Even if they are targeting the BCMA antigen, they will differ according to the co-stimulatory domain, according to the condition therapy that is used, murine, humanized. We have now in this meeting, look the number of abstracts, 14 abstracts, oral abstracts on CAR T cells. The most mature data correspond to the BB2121 and the Legend 1. And in these two studies, you can see that the majority of the patients respond, 80% of the patients responded. A high proportion of patients achieve minimal residual disease negativity, and the median PFS is ranging between 12 and 15 months in end-stage disease. I should mention that the cohort of patients that were included in these two trials are different. These have received 3 lines of therapy, these have received 7 lines of therapy, but again, this is very good results, but the patient still relapse. Then we need to improve. We need to improve also in the consequences of the safety profile. CRS is very frequent. Also, neurological toxicities can occur, and also hemophagocytic syndrome can be observed in some of these patients. And I mentioned that we have now, the good news is that we can improve on the CAR T cell therapy by using humanized, also allogeneic CAR T cells could be a possibility. The safety marker gene in order to extinguish a CAR T with too much activity, combinational strategies using checkpoint inhibitor or IMiDs together with the CAR Ts, or to use bispecific CARs, a specific population, particularly central memory, or antibody-conjugated T-cell receptors. In other words, I think for the CAR Ts is just the beginning of a beautiful story that probably we are going to drive together in patients like this one. And this is my conclusion. The discovery and development of new therapies addressing a variety of therapeutic targets is already changing the natural history of multiple myeloma. Understanding the mechanism of progression and immune surveillance escape, as well as manipulation of the autologous immune cell and gene editing, are opening new frontiers in the treatment of this difficult disease, such as multiple myeloma. And probably for the future, the combination of immunological approach with this novel different class of drugs, but particularly using this approach early on in the disease and not at the last stage of the disease, will change the future of myeloma. And I will close my presentation with this slide. As you know, Vincent Rajkumar is the editor for Blood Journal Cancer. Many of you, not my grandson, but me, try to submit papers to journals. And it's not easy to get a paper accepted. Do you agree with me? Very, very tough. And I sent this letter to Santa Claus recently, and I forward to Vincent, and you know the reply? Choose the color of the dragon. Thank you very much for your attention.
So thank you so much for this presentation. A tour de force, ending with the very exciting immune therapies. And so, any initial comments from our colleagues here? Besides the color of the dragon?
No, outstanding presentation, Jesus. The problem with relapse myeloma is that the choice of regimen is going to be affected by so many factors besides the ones that we usually deal with in the newly diagnosed setting, including the timing of relapse, the aggressiveness of the relapse, and who is the patient who's having the relapse, and most importantly, the availability of the drugs. So what is your go-to first-line relapse? Since I'm going to present the algorithms, I might want to know this.
No, I think to do a presentation on relapse is almost impossible. What I try to share with you is the data. Only to put the data, and this table that include all the comparisons with the increase in the months of PFS, the data on the high risk, is just to share data with you, because the only way to do the right decision is to be in front of the patient and to know what has he received before and what is the type of relapse. It's completely different one patient from the other. And I try to go through one singular patient, but as Vincent has mentioned, the patients are different, everyone.
Yeah, Philippe?
Yeah, well, Vincent, that's very important to try to define a sort of strategy according to the frontline treatment, for example. And we discussed during this interesting symposium how many patients are going to receive LEN frontline. And based on the talk given by Brian, we will have more and more patients that are going to receive LEN frontline, LENDEX. VRD in the SWOG study, followed by LENDEX until progression. Or LENDEX in elderly patients based on the first study. That's LENDEX until progression as well. In young patients, LEN maintenance until progression for the majority of the patients. So we will have, at the end of the day, plenty of patients, the majority of them, progressing on LEN. So what to do at the time of the first relapse? The strategy is based on the frontline treatment for sure. Then we are going to switch of agent, and to be honest, and very well presented by Jesús, we are going to use PI-based combinations, so VD plus something or KD. So what is best? Probably VD plus daratumumab. That was one of the proposals. First relapse, VD Dara, median PFS, 26 months. So if Dara is available, let's do it. That's how we are going to try to select the optimal sequence of treatment.
Right, absolutely. So we have time, just to remind everyone, we have time for a few more questions. We will re-ask the question, and then just to let you know that we will be doing the algorithms at the end, as we usually do. So we want to be sure to leave time for that. So any immediate questions? If not, why don't we, so that we have time for the discussion, let's go ahead and re-ask the polling questions. So we asked in Jesús's patient, as we were just talking about, this is the patient who was treated with lenalidomide dexamethasone, and then...
I can summarize. This is the
yes.
This is the third relapse. The patient has been treated up front with the transplant, then he received Cyborg-D, then he has progressed under Lendex, and this was the question here.
Yes.
It should be kept in mind that this patient has not been exposed to a monoclonal antibody so far.
Yeah, just
It's
to
just
be
oriented.
aware. Not that that's important, but you know. Okay, so we have.
It was good orientation.
Yes. So now we'll be exposed to a monoclonal antibody. All right.
And the final question is even more challenging because the patient has now been exposed to a monoclonal antibody and then has been exposed to everything and has progressed under everything.
Darapomdex. Yeah. These are very tricky questions, as we've seen from the discussions. And then, what do we have after that? We had one where, can we go forward to the late relapse?
Can you move to the next one?
Yeah,
this was the final situation.
There we go.
The patient has been exposed to everything and in fact has progressed with extramedullary disease under DARA-VD.
Yeah, so I think this is interesting. Having gone through all of these things, what would you finally select? And if we can go to that series of options.
That is a good point because the only drug that has not received is pomalidomide from the ones that has been accepted.
If we can go forward to the options for this one. There we go. Okay, so.
Neither carfilzomib. Okay, I don't want to orient.
Right, so the patient has not received pomalidomide. Oh, very interesting.
Very good.
Aha. So the level of enthusiasm for CAR-T went down. Yes. Stick with what you have, carfilzomib Pomdex. Okay, very interesting. And Elo-Pomdex.
If I am allowed,
yes,
probably is not going down, but we have realized that still this patient has options because he has not been exposed to carfilzomib pomalidomide or ilotuzumab pomalidomide, and this is the New England.
Yes.
Okay.
Yeah, the Elo-Pomdex data were actually surprisingly good. These data are just published in the New England Journal. Yes, so these are real options. So anyway, thank you for this very, very excellent review of these relapse options. And so in closing, I would invite Vincent to come up and just take us through, well, having thought about all of this, what are the algorithms heading into 2019? So please welcome Vincent again.
So what I'm planning to do is just 4 slides, just try and summarize all that you've heard so far. Some of these are fairly good recommendations. Some of these you can see the uncertainties. So first of all, we'll go with the principles. As you heard, we have made a lot of advances in myeloma over the last 10, 15 years, mainly because many of you have put your patients on clinical trials. Many of you patients have been willingly enrolling in clinical trials. So we are learning new things and we are advancing the disease. So in any situation, whether it's newly diagnosed, maintenance, consolidation, relapse, try and see if there is a clinical trial available, and clinical trials are always preferred over any of the algorithms that I'm going to show. And what I'm showing is mainly assuming that if you have access to the drugs that we are talking about, what would you do in the ideal circumstance? And I'm using only commercially available options. So first algorithm is for patient with a newly diagnosed, possibly smoldering or multiple myeloma scenario. I already showed you the slide before. Clearly, if the patient has myeloma-defining events, all of us will treat as myeloma. If the patient doesn't have myeloma-defining events and fulfills criteria for smoldering myeloma, the first step to do is to decide whether the patient has a high-risk smoldering myeloma or a low-risk smoldering myeloma. The main features for high risk will be cytogenetics like del17, gain1q, or a 414 translocation, or a very high M spike like more than 3 grams per deciliter, or a very high free light chain ratio. If patients have low risk smoldering myeloma, then clearly observation is enough. Every 3 to 4 months, you want to follow the patient. If the patients have high risk smoldering myeloma, there are a number of clinical trials, all the way from single agent daratumumab to the full-blown ASCENT trial with KRD, DARA, maintenance, and so on. I do feel like there are patients with high risk smoldering myeloma who are at very high risk of progression, particularly if they have evolving features. That means if the M spike goes up by 0.5 gram and the hemoglobin falls at the same time by 0.5 gram, those patients we have shown have almost a 90% chance of progression. And so you want to take into consideration patients with evolving features and patients with multiple high-risk features and consider therapy in them in light of the Spanish trial, which showed a significant prolongation in overall survival with early intervention. As far as myeloma frontline treatment goes, I think most of us can agree that we would first try and separate patients into transplant candidates and non-transplant candidates. And if bortezomib Lendex was available, then using bortezomib Lendex for 1 year, followed by Len maintenance, would be the standard. VTD or VCD can be used instead of BRD if lenalidomide is not approved frontline. There is an abstract at this meeting looking at whether we need to do the dexamethasone. Can we just do 1 year of BRD and then do Len alone rather than Lendex, so you can spare some side effects? I would encourage you to look at that abstract and go to the session. Preliminary data suggests that you don't need the steroids. If the patient's a transplant candidate, I think most of us agreed we'd go with the VRD induction, autologous stem cell transplantation, and lenalidomide maintenance. The only exception would be for high-risk patients, we might use a bortezomib-based maintenance. This could be either bortezomib alone or bortezomib Lendex at low doses. I agree with Dr. Moreau that we don't generally prefer a delayed transplant, but there are some patients, standard risk, patients really not keen on wanting a transplant at this time. If I had myeloma, I'd probably be like that because I want to just go on with my life and I'm willing to take the risk. Given that overall survival is the same, I think delayed transplant is a reasonable option, but if you're going to do delayed transplant, number one, you should be able to harvest the stem cells and freeze it forever. Number two, you must be willing to use it at first relapse, not wait for second, third, fourth relapse. In the first relapse, I think Dr. Moreau mentioned that really everything depends on whether the patient's been exposed to lenalidomide or not, because most of our patients are going to be relapsing on lenalidomide maintenance, whether it be in the post-transplant setting or in the frontline setting. If they are clearly refractory to lenalidomide, then I think, if they are not refractory to lenalidomide, let's say they have not been on lenalidomide or they're taking very small doses of lenalidomide, then daratumumab Lendex is probably my reasonable first line option. If they are refractory to lenalidomide, on the other hand, daratumumab bortezomib dex or daratumumab Pomdex. So basically, I'm favoring a monoclonal antibody-based regimen for the first relapse, based on the fact that the hazard ratio for DARA-based regimen seems to be much better than the others. It's really not fair to compare like that, but there are no head-to-head triplet DARA-RD versus KRD or any such randomized trials, so we have to rely on these kind of unfair comparisons. Having said that, I will tell you that it's very unlikely that your patient's going to do worse if you picked a different regimen and say KRD first and then went to DARA-Pomdex or vice versa. I think it's most important to have access to the regimens and go some logical fashion with one regimen after the other rather than there's no one right answer. But here are some options that I've given. Almost all of these are approved with the exception of Cybo-D and Ixa-Pomdex and Car-Pomdex, all of which are active regimens as well. Always consider a salvage autologous transplant in eligible patients. Nowadays, many patients may not have had a transplant, and you might want to tell them that the first, if they're eligible, a transplant as the treatment for first relapse might be reasonable. After the patient has failed for the first time and now you're talking about a second relapse, the problems become even more complicated. As we said, it really depends on what all regimens they've received before, how aggressive the relapse is, what kind of performance status the patient has, and so on. I have two simple principles. Number one, if you're going to change a regimen or if you need to change a regimen, use a triplet at a minimum. And number two, have at least 2 new drugs that the patient's not refractory to. And that way you can come up with regimens. We have plenty of them, so you can go on sequentially for multiple lines of therapy. So any of the first relapse options are reasonable. In addition to that, there are some additional options you can consider. Some patients who have very aggressive relapse might need a VDT PACE type regimen. Melphalan is still a great drug, intravenous melphalan at a single dose or even oral melphalan in combination with other drugs. Venetoclax, particularly for 11-14 patients. Bendamustine-based regimens. Adding panabinostat to proteasome inhibitor-based regimens and starting to try 4 or 5 drug regimens may all be reasonable in the absence of clinical trials. Of course, clinical trials at every step needs to be considered. That's all I have, and thank you very much for all your attention. We're happy to answer questions.
Thank you so much, Vincent, for this overview summary, which I think is very, very helpful for everyone as a takeaway from this afternoon. And so we do have a few moments. If there are any pressing questions, we can take them from the floor, or maybe the yes? Yes?
No, I think there is a question before.
Okay, please, go ahead.
Thank you for the... Do you hear me?
Yes, go ahead.
Thank you for the excellent talks. I have a question. Would like to have your opinion on how you would treat a patient with monoclonal gammopathy of renal significance, especially given that those patients will have an elevated creatinine, based on if they have coexisting diabetes or because of really monoclonal gammopathy. I would like to have your opinion on how you would approach those patients.
Okay, so a tricky situation. What do you think, Vincent?
So it's the same thing as the neuropathy question that we have talked about. A lot of us get consults on patients who have a monoclonal protein, and for some reason or the other, they have an elevated creatinine or a proteinuria, but it's not CAS nephropathy, so it's not multiple myeloma. What do you do with these patients? I think the first step is to figure out if the M protein is the one that's causing the renal damage or something else. And that may require a kidney biopsy. Without a kidney biopsy, you cannot make that conclusion. MGRS is like a very general term used to describe a variety of different diseases. And you have to really know precisely what MGRS disease are we talking about. So the main ones to keep in mind are membranoproliferative glomerulonephritis and C3 glomerulonephritis, both of which, if you can find monoclonality on the biopsy specimen, then that tells you that it's a renal damage that was caused by the monoclonal protein. And for those patients, we have considered therapy with myeloma-type regimens, such as Cybordi. If the patient has light chain deposition disease or heavy chain deposition disease, then we treat provided there is something to be treated. That means the patient's not in end-stage renal disease. All the other nephrology problems are either rare or there's very, very little data to go into.
I see. Like, how long do you treat it, Cybordi?
I would say probably 4 to 6 months. We have an algorithm. There is for those of you interested, these are complex topics. If you Google the Mayo Clinic proceedings, you will find 2 recent reviews, one on monoclonal gammopathy associated renal disorders and another one on monoclonal gammopathy related neurologic disorders.
Thank you. Thank you for that. Very helpful.
Right here.
So we have one more question here. Go ahead. Yeah, it's working now. I think so. Yeah?
Thank you to all of you for very beautiful presentations. I really enjoyed it. I have a question to one of my own patients. So she's an elderly woman, not so elderly. She was induced with 4 cycles of VRT, got autologous transplantation, consolidation with 2 cycles VRT. I had the bone marrow also tested, so she was in a complete response, and within very short time, I saw a tumor in the iliopsoas, so in the muscle, and it turned out to be an extramedullary disease. So how would you treat this patient in the first relapse now?
All right, so early progression, presumably high risk in some fashion. Any thoughts?
No,
So it's VRD,
VRD,
transplant,
yeah,
and
consolidation for 2 cycles, and then relapse very quickly with extramedullary disease.
okay.
And bone marrow is still okay.
Bone marrow is okay, right?
yes.
Bone marrow is still okay.
In that particular patient, I will use by sure a monoclonal antibody because he has not been exposed to a monoclonal
Absolutely.
antibody. I will use pomalidomide because
Yep.
he has not been exposed, and if possible, also a different proteasome inhibitor, carfilzomib. I will try to treat this patient as most aggressive as possible because this is a very poor prognosis patient.
Yeah, those are some simple options. Okay, all right, we have one more, and then I think we'll close, okay? So this final question,
Thank you very much for this nice presentation.
you speak up?
I would like to ask a question about the management of CNS myeloma. Any
CNS
suggestions
myeloma,
there?
okay.
Thank you.
All right, well, this is a rare one. Does anyone want to comment about that? Shaji,
So
Shaji, all right, you're selected.
I get the most easiest question of the all, right? So, no, I think it's always a challenging condition to treat. Obviously, I think the main thing is, at least our practice has been in those patients to try intrathecal therapy to clear this CSF, mostly with the triple therapy combination, but then follow that up with systemic therapy using, again, multi-drug combinations that we haven't used. We don't have very good data on how well the monoclonal antibodies necessarily get into the CSF, but I think using at least we know pomalidomide gets in reasonably well the IMiD. So using a multi-drug combination, an IMiD, preferably a monoclonal antibody, and maybe even using a proteasome inhibitor in that combination. There are some ongoing trials looking at some of the newer generation proteasome inhibitors with better CNS penetration. That may be part of clinical trials. So see if there's clinical trials. If not, then this may be a reasonable approach in those patients.
Yeah,
all right.
If I am allowed just to add, pomalidomide partially crossed the barrier, and
So-
this is one possibility. Dara is not clear, but it's being claimed that also partially. Marisomib, that you were alluding, probably will be the drug of choice, but they are not developing in this situation.
Obviously very difficult, the
Yeah.
prognosis.
I have a completely different issue, particularly for Vincent. Usually in your presentations, you emphasize the need to confirm a CRAB symptom. For instance, if you have a myeloma patient that has only 15% plasma cell in the bone marrow and has anemia, you recommend always to exclude other causes of anemia. But the same would apply also for smoldering patients that have a dubious focal lesion or an increase on the free light chain that is not expected. Would you mind to comment, because I think this is a very important just to confirm in this particular type of cases that the result has sense?
Yeah, I think the concern about the free light is important.
So again, to paraphrase the question, which is just absolutely very, very important, is that if you're going to take a patient who doesn't have any symptoms and say that you have multiple myeloma, I'm going to start therapy, we better be really, really sure. So we have laid down criteria in terms of who is called as myeloma, but that doesn't mean we need to, we can suspend judgment. We have to use a lot of judgment to see if this is really myeloma and if this patient really needs to be treated. Clearly, if the patient has 70-80% bone marrow plasma cells, that's the easy one. The free light chain ratio more than 100, in general, I'm very comfortable treating, provided the involved light chain is high. If you have a patient where the urine monoclonal protein is completely negative and the free light chain ratio is high, you have to ask yourself, is this patient really making a lot of free light chains, or is it just having a problem excreting them? And if they are dimerizing their light chains, and that's why the free light chain ratio is up, those are not the patients who need to be treated. So we do need to get the 24-hour urine protein electrophoresis. Make sure that whatever high light chains you're seeing is also seen in the urine, which means that the kidney is under threat and you need to do action, and those patients we need to treat. Otherwise, you might be just wanting to watch them. Same thing with the MRI. When we wrote the paper, we said you need to have unequivocal focal lesions of 5 millimeters or more, and you need at least 2 of them to be considered as myeloma. And we said, if you have a doubt, please don't do anything. Wait for 3 months and repeat the imaging.
Very important.
Because there is a study which shows that if the number of lesions goes up or if the size goes up, then they really progress to myeloma quickly. But if it doesn't change, then the risk drops. So there's no urgency to treat myeloma. So keep that in mind and always repeat imaging if you're not sure of it. Always repeat the light chain, check the urine, and make a judgment call, particularly asymptomatic patients.
All right, so these are very, very helpful final thoughts. So thank you. So let's give a great thank you to the panel here. And thank you for joining us this afternoon. So thank you.